Yeah, we have Dr. Felipe Pittella, Norwood 6, Norwood 7 specialist here. For some reason, it's not launching on the forum. What does this say, Jerry?
Can I start the live topic? Please try again later.
Okay. I guess. Uh, Sorry, guys. We'll have to. Can you? All right, there we go. Error occurred. This is the first time we're trying to stream it also on the forum, Hair Restoration Network. For some reason, it's saying an error occurred. Can you refresh it? No. What the heck? Go on my YouTube and actually link my actual go on the on no on the right here on the actual laptop. Yeah. Go on my YouTube. Go to the YouTube icon and then go on the actual stream. That because I think I was no go on the main. No, no. Yeah. Now where it's streaming, right there. Click on that. There we go. All right, so perfect. So take the URL.
Copy here.
Yeah. Now go to the forum. This is technical difficulties. Hopefully that'll never happen again. Uh, is there something where it allows you to update it? I might just have to. Here, hold on. All right, guys, 1 second. Let me. um, That's the URL, right? Um,
Thank you very much for the compliment. Best MMA promos. Thank you very much. I'm really glad with your words. And this Verteporfin, yes, I want to know about it. Yes, several patients have asked me about the Verteporfin, and I'm really interested on it. But I have no idea what it is, how it works, the mechanism of action that this Verteporfin does. I don't know, you know. So if there is anyone who could tell me about it, I will gladly hear and maybe even use it on my patients. Because the thing in hair restoration is not the bald area that I need to cover, but the resource that I have to cover it. If I have no resource, there's no surgery. There's no good surgery. Really difficult to perform a surgery without resource, without donor areas. So if this Verteporfin really can heal the donor area, it would be a very game changing in the hair transplant industry. Yes, indeed. I mean it.
Oh, sorry, guys. I was trying to stream live from the forum, and it seems like for some reason it's just not working. So, Dr. Patella, to talk to you a little bit more about verteporfin because it's something that everybody's interested in. It's something that I've been pushing because I think it's gonna revolutionize the hair transplant industry. What it is, it's FDA approved for the eyes under a drug name called Visidyne. It stops the pathway and the fibroblast in the creation of scarring. So it basically prevents scarring. So what researchers found was when they injected wounds into, oh, what the heck happened? Did he just, we dropped him? Oh man. All right, this has been a podcast full of issues here. Hopefully he will come back on. Let me send him a message here. But in the meantime, you guys ask questions. I'm gonna try to get him to do verteporfin. Um, we get a global effort for verteporfin, and we can get more doctors signed on. I'm going to be meeting with Dr. Mohebi in LA, hopefully in the next week or two, along with Dr. Rasman, who is a researcher as well. And Dr. Mohebi has connections in UCI and UCLA. So if we can get it, if he does a trial, it's going to be actually done the right way in a hospital setting. There we go. He just joined back in. Sorry. All right, he joined back in. There we go. We lost you.
Yes, I'm here again. I'm sorry for that. I don't.
You cut out there.
Are you there? Can you hear me?
Yes. Yeah, I can hear you now. Yeah. So, like, what I was saying was, in regards to verteporfin, what is it? What it is it basically prevents scarring. So, researchers at Stanford created wounds on a pig, which pig skin is very similar to human skin.
Mhm.
When they injected the wound with verteporfin, they found that not only did the wound regenerate, but the hair follicles regenerated as well. So there was no scarring, and the hair follicle, all of the dermal appendages, everything regrew just fine. So Dr. Barghouthi and Jordan did the first human trial, and I believe he's reaching his. I think he's at a year now, and he's doing another trial as well on different patients. But his trial was very intriguing because the hair looked at least double the amount in the test area versus the controlled area. So he did a small section where he did an equal amount of extractions, right? And he in one section he injected the verteporfin, and the other section he didn't, and the hair looks significantly better in the test section. Now, not all of the hair grew back, but it seems to be at least, I would say, 35-40% of the hair grew back. But obviously this is one patient. It's not, the study wasn't done perfectly, but I think at the very least you can significantly reduce scarring, FUE scarring. Now I know the scarring is already pretty good, but the interest has been.
I'm sorry, just to add something very interesting. I just made the markings of the patient that I'm going to operate him tomorrow, and he's a Norwood class 6. I will need 2 procedures, and he wanted to do one procedure tomorrow and the next one only in November. And I was talking about the fibrosis that we may have in the first surgery, so that in November in the next surgery he would get a little bit. I would need a little bit more time to harvest from his own area that have already been explored. So this is because of the fibrosis. I don't know if the verteporfin helps with the fibrosis. Is already a very good outcome if it prevents
The fibrosis under the skin.
Yes, a high level of fibrosis. Yes, it will be already a very good outcome.
I think without a doubt it does that. I mean, I think that's proven. The question mark that a lot of people have is, will it regrow hair? That, from what I've seen on one patient, it looks like yes, but of course that's one patient. There's a lot of variables at play, but I think definitely the more people take interest in it, the more people start doing these trials, the better it's going to be. Because I think that 100% it's going to help with fibrosis.
And Melvin,
100%.
do you know if he's doing a multicentric trial, like with a lot of surgeons from several countries that can, add to this article? I don't know about it. Maybe he's researching by himself, but if he's doing some multicentric trial, it would be much easier to reach conclusions, to reach the truth behind it.
So far, I only know of one doctor who he's doing a trial with, or at least helping, and that's Dr. Saifi in Poland. Um, and so that's the only doctor. I've been the only one really that's really been. I went to the LA Hair Restoration Conference. I was in a panel of at least what 6, 7 doctors. I was trying
I
to,
saw that.
promote it and try to get them to do something, but a lot of doctors are sort of hesitant or they don't want to do it. So I'm really pretty much the only one, but I would love to hold a conference. I mean, I think this is what my goal is ultimately. Um, Ultimately, I would like to have a panel of our hair transplant network doctors doing the study, comparing notes, and having at least maybe 2 or 3 patients that they're doing the study on. And then at the maybe next year or maybe 2025, do a conference with all of the results and sharing all the results and stream it live. I have Dr. Arshad in England who has a humongous hospital in Leeds. He already said that he would give his help us out and give us the hospital location where we can do the live conference. So that's my ultimate goal. Ultimately, it's good for everybody. And we're not
Yes.
trying to do anything besides improve the results. And I think it's something that, to be totally honest and candid, just so that people know, if it does get work, it's going to be expensive. One bottle's $3,000. So if you want to have this added to your procedure, you're looking at a higher cost, but I mean, it's worth it. I mean, if it's going to regenerate hair, you're going to get, double the amount of donor. I don't know if there's I think the patent ended. I mean, I think there's just so many opportunities here for another company to make a generic version of it, to make it cheaper. Could we reach out to the actual company and is there enough interest for them to actually make a version specifically dedicated for the cosmetic field? I don't know, but there's so many questions
Yeah, I think this may be really a game changing in the hair restoration industry, because I to restore those Norwood class 6 and 7, I really extract, I really harvest in the edges of the donor area, and almost reaching the limits that those donor area have to give me. So if I can increase that donor area by 25%, this is a really big, a goal. This is a really big thing, so if it's really true, I don't see why all the patients are not using it. It may be expensive, but eventually the price are going to be more
reasonable. Well,
yes, reasonable for the use of all patients.
streamlining it would be the goal. I mean, the step number one though is to get doctors on board to actually try it, to do a study. So since you're here and we're talking to you here, would you be willing right here in front of everybody? And this is going to be on YouTube, and these Verteporfin videos are pretty popular, and they get shared on Reddit and all these places. Will you be willing to do a trial? If I connect you with Dr. Barghouthi and we can get you some Verteporfin sourced to you, are you willing to have some patients try it out? Maybe ideally it would be like 2 to 3 patients local local to you that you can see every 2 to 3 weeks, um, and take pictures and
Absolutely. I would do it absolutely, of course, because I would choose one of those very difficult case and map the donor area precisely so that I can understand the outcome
I'm
from the area that has the verteporfin and the other area that has not the verteporfin applied on it. So yes, absolutely. I mean,
I'm
just
gonna
make the connection between me and Dr. Barghouthi, and we'll settle things.
I am doing that as we speak, guys. I'm gonna send Dr. Barghouthi's information to Dr. Pittella right now. Let me find his. Here we go. Share.
Someone asked you to tell about the pathology of a patient with the 4 milligram of verteporfin. What is this?
Share the okay, boom, done, guys. We got another one. His question is: share the pathology of verteporfin. Is that his question?
Here.
Yeah.
Yes, he's asking you to tell about the pathology of the patient with the 4 milligrams of verteporfin. What is this?
Okay. Yeah. So he's asking if you've seen the pictures and the study of Dr. Barghouthi. I don't think I've sent that to Dr. Patel. I think, well, maybe I did, but I'll resend it to you. His latest pictures that he posted, using
Please.
0.4 verteporfin, which was the most impressive results. I'll share it with you. I shared you his contact, so if you can reach out to him, and that way he can hopefully get some of those bottles sourced to you, and we can start this. The more doctors get on board and start trying this out, the better it's going to be for everybody. I've tried to, on the forum last year, I made the thread, the verteporfin thread, and it's, I think, one of the most popular threads in the history of the forum. It's got like, I don't know, close to 1,000 posts and 120 something thousand views, and it just keeps growing, and it's not even a year old. I think I created it in July. So the interest is there. The people want this. They want to see this. They want to, even if it's like I was telling the doctors, I said at worst it helps the scarring. At worst,
Yes,
it
yes,
prevents the
yes.
fibrosis. And for a surgeon like you that does 7,000, 8,000 in one session, that's huge, because you do a Norwood 6 and the next year you want to do more, then you see all this fibrosis and it makes it more difficult. It's harder for you to keep
Yes,
doing
absolutely.
more surgery. So for someone like you, even if it doesn't regrow all the hair, it's still worth it because it's preventing the fibrosis. So I think it's something
Yes,
that
absolutely. Yes, that was what I thought, because when restoring a very large Norwood class, the most important thing is the resources, is whether the patient uh, has or not the availability of donor grafts to cover all the areas, the balding areas with good density. So if the patient has that areas, okay, we can restore it. But if he does not have, what we will do, we have to try to do body hair transplant. And the body hair, well, it's a good solution, yes it is, but if the hair of the scalp could be transferred everything to the bald areas, it would be much better, and the result would be much greater. So if we can recover, regenerate, or whatever verteporfin does, 20% would be really good for a very high Norwood class. That's it. I believe if it's really true, it will be a really big change in the hair restoration industry, and the worries about over harvesting will be like much minimized with this medication.
Yeah. Can you imagine it in the wrong hands though? Imagine like these hair mills getting a hold of it and trying, well, I mean, I guess in a way it would still be good for the patient because they're not, they wouldn't be completely decimating their donor area. You mentioned, and I want to go ahead and show the audience some of your work here. So let's do the share the screen to his Instagram page, just so for those of you who aren't familiar with his work, we're going to show you some of his work here on Instagram. And if you guys don't follow Dr. Pittella on Instagram, definitely give him a follow. So we got right here his site. These are some of his patients. Go down. Let's pull one. All right, let's do that one. So let's go, yeah, that one. So this is a class 7 actually. So this is a class 7. Can you go to the next hit the next slide? No, my bad. Go back. So the small one right there. Yeah, there we go. All right. So this is a class 7 large head. And just so if you can explain, what is the difficulty with being a class 7 with a large head versus a class 7 with a small head?
Yeah, the main point in hair restoration, it's pure mathematics. So if you have an area to cover, you need to put on that area a good density so that the hair looks natural. The hair transplant will looks natural only if it gets density. So if you have, for instance, Norwood class 7 with a small head, the amount of graft that you need to restore it would be much lower than if the same patient, the same class of Norwood 7 would have a very large head. So what matters in the end is not the class of Norwood, but the size of the bald area, the size of the balding areas. So I'm doing actually I've published an article talking about this, and there are several patients that have Norwood class 6 that need more grafts than a patient Norwood class 7. Why is this possible? Because a Norwood class 6 with large head will demand much more grafts than a class 7 with small head. So also I've transplanted to patients with Norwood class 3 that they demanded more than 5,000 grafts. This may sound like what, but if the patient has a large forehead and if he wants to have a hairline on on the limits that I can transplant to it, and restoring also the temple points, so I will need a lot of grafts to restore it. So sometimes in class 4 I need more grafts than in class 5 sometimes. So what matters is the area that I need to cover. Like this guy is a class 6 to 7, but he has a very large head, which means that only to restore the first 4 square centimeters from his hairline, I needed almost 4,000 grafts only for a small piece of lane in the hairline. And the rest, in this case, I used more than 13,000 grafts in 3 surgeries. Yes, it was a really hard
Let's go to the
case,
next one.
a really big challenge.
Wow.
And I needed to use a lot of beard and chest graft as well. because he didn't want to, use all his beard.
How
And
many
yeah, we managed
scalp
to
grafts did you do for him?
maybe around 9,000 grafts. I'm not 100% sure, but it was way more than 8,000, maybe
Go to the next
around
one.
9,000 grafts.
Wow.
Fortunately,
Next one.
this guy had
Next.
a very good
Wow.
donor area, very thick donor area and large donor area. So I've managed to harvest a lot of grafts from it.
And
But
his
even so, I needed a lot of body hair as well.
like hair quality is kind of like coarse and curly, right? It looks kind of like it's thick. Like he has
Yes.
thick hair. So that makes a big difference.
Yes.
Let's go to the next one. Let's see if we can see
Yes.
the there we go.
Absolutely.
Yeah, like that makes a huge difference, but it's still amazing. I mean, that's amazing. Let's go to the next one here. Wow. I mean, this was impossible 10 years ago. I don't see anybody besides you and Dr. Sethi Eugenics and Zarev doing these type of humongous cases. Let's go to the next one. I want to see the crown. Do you have pictures of the crown here? Next. There we
Yes,
go.
yes. Maybe the last one.
Yeah, so that's the crown.
So even yeah,
It
if
looks
the crown has a lower density than the front, but it still have good density.
what is the biggest problem with the crown? Because that for someone like, and I've always tell people this, um, once the crown goes, you're in an uphill battle. You're you're fighting against the tide because there's just so many grafts that you require to make it look dense. How many grafts here did you put in the crown?
In the crown, at least 4.5 thousand to 5,000 grafts.
Wow.
Yes,
Jeez.
it's really hard to restore the crown because you need high density in the center of it and also in the periphery. Because if you don't fill the periphery, you will get like a gap between the dense area and the donor area. And it's very important also to like try to match the contrast between those areas. In high Norwood class, you need to match the contrast between the transplanted area and the donor area so that you don't get the gaps and the difference of density of darkness. You get a darker donor area compared to the transplanted area. So this is really important to get good density all over, especially on the periphery. If you notice here that his side humps,
Yes.
to restore a side hump, you need almost the same amount of grafts to restore like a receding
hairline.
corner.
Wow.
Yes, you need a dense
Go to
side
the
hump
previous
because
one.
usually the patient combs the hair and
Previous.
yeah,
Keep going.
the other one.
There we go. So right there, you
This
see
one.
the just the little lateral humps. That section right there. If you especially towards the end where it dips down by the crown, which is an area that is often underused. A lot of doctors don't pack that many grafts in there. It's gonna look odd. It's gonna look like there's this little section,
Yes, unnatural.
this little section that's balding, and that's really a pain and it's a pain in the ass. I know that's where I got my last surgery at, was that because that was such a difficult area to disguise. But even still, it's not
Yeah.
perfect. So for this guy, it looks absolutely perfect. I mean, it looks like wow. How many grafts did you put in the laterals?
I'm not 100% sure right now, but possibly 1.5 to 1,000 grafts on each one.
Wow.
So that I
That's
can.
too.
It will depend of course, the size that you consider it.
Yeah.
This guy, have a very large head. So his lateral, his side humps goes, a very wide area.
Yeah.
Maybe I'm talking about 15 square centimeters, each
Side.
lateral, each side hump. Yes, each side hump, which gives us 30 square centimeters. And to get a good density, I mean 50 grafts per square centimeter. So I would need, yes, 1.5 thousand grafts to restore it.
Let's click out of this one, and you mentioned square centimeters, and you followed something very like mathematical. So do you, when you're storing a Norwood 6, Norwood 7, are you taking into account like the square centimeters? Are you like mapping out the area, like the crown? Okay, this crown is, let's say, 150 square centimeters or 200 square centimeters. Are you then taking the graphs and figuring, well, to get a decent density, I need at least 20 grafts per square centimeter, or do you follow that type of formula when you're restoring?
Of course, absolutely. This is mandatory. All cases I do this
Oh, so
because yeah, I'm sorry. Go.
so I want to take a case where you have, sort of the graph placement. Go down, Jerry, so we can, like, what would be a good case that you could showcase that on your Instagram? Would it be this super mega?
Yeah, this one, yes.
All right, let's click on the super mega right here. So that and the graph
I tell you
placement.
what I did on this case.
So you have all the graphs placed.
It was an
Yeah, sorry. You have all the graphs placed here, and you have some of them are blue, they're marked blue, or you have like an ink to differentiate between the hair. Do you know, like, are you doing less graphs in the crown and gaining density as you go forward? Are you, like, let's say for example, in the crown you're doing 20 grafts per square centimeter, in the mid scalp maybe you're doing 30 grafts per square centimeter, and in the front you're doing 40, 45. Is that how you
it
stagger it?
yes, it will depend on the approach that I've chosen, that I've set up with the patient. For instance, usually a patient with Norwood class 6, one procedure won't give him a good result, because
Yeah.
let's talk about 6,000 grafts, 7,000 grafts for a class 6. You will need to do this kind of approach, like put a high density on the front area and do a less dense mid scalp and crown area. So in such case, if the budget it's too high for the patient to afford it, and he is a class 6 and wants to do a procedure, I try to put a higher hairline and put a very good density on the front, and do this gradient, this reduction of density until I reach the posterior parts of the crown. But this is not the best approach for those cases. The best approach would transplant good density to all those areas. So it's mandatory to measure the area so that you can figure out the exact amount of grafts that you need to restore with good quality those patients. I've came up with this classification for baldness, for male pattern hair loss, that we call it precise scalp area count, or just precise, in which for each 30 square centimeters the patient of bald areas, the patient will score 1 point in the scale. So if
Oh, I think we lost him. Dang it. We lost him again. Here, let me send him another message. Wow, why does this keep happening here? All right, let's see if he will rejoin. Um, what are some of the questions that we got in the chat, Jerry?
They're asking about the patient. Is this patient on any medications? I believe it was that first slide.
The first slide. So, so for those of you who don't know, Dr. Pittella does not prescribe finasteride. Oh, there we go.
So,
all right, so we got cut off again. So someone in the chat asked if the patient that we showed the first slide, if he was on any medication. So if you could just kind of give a brief,
yes,
what's your protocol for patients?
usually I prescribe for all my patients minoxidil, oral and topical. Oral usually I start with 2.5 milligrams for men, and I may raise the dosage within 6 months or a little bit more, and also ketoconazole shampooing and biotin, vitamin B7. That's what I prescribe usually to my patients. And just to mention it, I don't prescribe finasteride because as we've talked in the last podcast, I wouldn't use it on myself, so I don't feel comfortable for prescribing it to my patients. And there are a lot of other reasons why I do not prescribe finasteride, but I understand that not doing so, not prescribing finasteride, puts me on a very hard situation, because I will need to do a much better hair transplant so that I can reach a good result without the use of finasteride. So I start with a huge disadvantage not using finasteride. But even so, I believe it's not good to my patients to prescribe for them. But this is my medical opinion. I know I understand that it's very controversial, and that's it. This patient was not using finasteride, only oral minoxidil, topical minoxidil, biotin, and also ketoconazole shampoo.
Perfect. So before you got cut off, we were talking about how your method of restoring a Norwood 6, Norwood 7 is, right? You use a very mathematical type of, almost like an
Yes.
equation, right? You look at it like an equation, like, okay, I have this head. We've got, let's say, 300 or let's say, what would you say the average head size is, balding area? 500 square centimeters, 400 square centimeters? If the crown alone,
180 to 250 square centimeters of bald area would be a class 6,
so you got, let's say
or
you
class
have,
7, maybe. Okay.
maybe, so class 7, maybe 300 square centimeters.
Yes, a little less depending on the size of the school, or even more,
Depending. So
depending on
you
the
look
size
at
of the
it.
school.
So you look at it like, okay, I have this area, this large surface area that I need to cover. So when you approach your surgery, I was talking about, do you strategize it where you place less grafts, less density in the crown, and you gradually go upward in density um, towards the front? But you were mentioning something like you only do this if the patient is trying to save money, or maybe doesn't have the necessary funds to do the entire surgery. So my
Yes.
question is, if someone came to you and said, look, I want to restore my whatever's necessary, however many grafts is required, what's your strategy?
Yes, great question. So usually I prefer to offer the patient the best result that he can achieve. That's my main objective is to give the patient a good result. So for that, I need good density in all areas that I'm approaching. So if I'm on the hairline, I need good density. Medium scalp, good density. Side humps, same thing. Crown is the same thing. So if I'm facing a Norwood class 6 and I'm talking about more than 200 square centimeters of pout area, I will need at least 12,000 grafts, 13,000 grafts, depending on the size of the school. So this may sound, what, that large amount of grafts? Yes, it is, but it's possible to reach a good result if the patient have resources. What are resources? Donor area. I'm talking about donor area. It may be on the scalp or on the beard, chest, abdominal area, and even axillary regions, and also pubic regions. Wherever the patient has good grafts to offer us, I would try to reach that best outcome. So in all the case that I perform, I measure the exact area that I need to cover. So usually a class 6 or a class 7 would need more than 12,000 to 13,000 grafts. And if the patient does not have that amount of grafts available for his hair restoration, what I do is simply do a strategical hairline, try not to lower it too much, to keep it a little bit higher, and also try to sometimes to put a lower density on the crown, even if it's really necessary. And this, I mean, if the patient does not have any donor area available for a very high hair restoration.
Do you
I'm not sure
have
if I
any?
answered your question properly.
Yeah. So basically, your goal when you're looking at and let's pull up a presentation here, Jerry, so people can also see, or it's already there. You just have to click on it. No. On the actual, yeah, the little tab over there. Yeah, right there. All right. So like taking this case for example, you got a guy like this. This is probably like a class 5. Go to the next slide. Trying to see if, okay, that's a good one. So this guy's probably like, what would you say, a class 5A
A
or
class 5,
5V?
I like to say that it's a class 5 heading to a class 6, because he has almost no hair in the median scalp, and his crown is enlarging a little bit. So the first thing to think about the hair restoration of this patient is to avoid further miniaturization of his native hair. So the first thing is to start immediately the clinical treatment. The clinical treatment is as important as the hair transplant. And for clinical treatment, I mean oral minoxidil and also biotin and ketoconazole shampoo, and if possible, topical minoxidil as well. So the first point is this: to stop the miniaturization of the native hair. And the surgical planning is simply measure the bald areas and plan the procedure accordingly, with good density in all the areas.
Yeah, so do everything equal density. In most patients, how many grafts can you do in one session, like on average?
Yes, on average, on a daily basis. I do not like to talk about amount of grafts. They ask me too much on Instagram about it, but Instagram is not the place to talk about technical issues.
Yeah.
But on a daily basis, I harvest more than 6,000 grafts on a day for the same patient. 6,000 grafts. Sometimes I harvest more if the patient
Sometimes.
needs more, or if the patient has a very, very good donor area. So this is what I do on a daily basis. Of course, I operate almost class 5 to 7. Only a few of my patients are class 3. I do not remember when I last operated the class 3. And so I need a large amount of grafts, especially because I try to follow very good densities on all areas. And for that, I need grafts. So the most important thing in the procedure is harvesting, is obtaining that graft so they can be wisely put in all
Yeah.
the balding areas as well. The balding areas, they also need grafts. Yeah.
I think one of the things that really impresses me with you is let's go to the next slide, is just that matching density. Go to the next one. I'd like to see maybe like a, this is the guy that we were talking about earlier. Go next. Just the crown and the lateral humps. That's something that really impresses me, because a lot of doctors will restore the hairline, restore the mid scalp, and leave that just empty void, or they put a little bit of grafts, and it never really satisfies a patient. I mean, it's better, right? But it's not it's not perfect. It's still, they still want more. How many patients on a daily basis, or how many patients in your practice do you see fully satisfied, Norwood 6s, Norwood 7s, that maybe they were using hair loss concealer, they were using Topic or something like that stopped using it? Or do they still always need that?
Yes, actually, when as I said before, when I'm facing a big challenge like a class 6 or class 7, I simply try to reach the best result that the patient uh, can offer. So usually those patients, they are satisfied with the results, and mm, they don't need to use concealers. They do not even talk about concealers with me. And the patient must understand that there is a process, there is a restoration that may take, 1 year, or may take 2 years, or even more. So in this patient, the large Norwood 6-7, large head, this patient needed 3 procedures. They were done within 3 years. So it's not that one procedure, 2 days of procedure, the patient will get the best result. Sometimes the patient needs more hair, and a refinement, or even another surgery would be necessary. For instance, in this patient, I want to uh, add some more density on this crown, and I'm
Mm.
already talking with him about about it. He
Does he
still,
have any grafts left?
yes, he still have a lot of grafts here on his donor area. And if you see the previous picture, you'll see a very sharp, a very thick beard that we can still use it. So as far as the patient has donor areas, we can, restore it and increase density and improve the result even more and more.
Now, what do you think about the issue with restoring one area with all beard hair? So, like, let's say, like for him, for example, he has a crown. Um, would Let's say he had no grafts left in his donor, all he has is beard. Do you think it would be a bad idea to use all beard grafts? Because do you think it'll look strange, odd? Would it look off if you use all beard grafts, or does it depend on the patient, on their hair type?
Uh, Yeah, this is a very good question, because I've sent you a photo of one patient a class 6 that I've restored with 2 procedures. And in the first procedure, I used only scalp hair to restore his front and mid scalp. And in the second procedure, I used only beard grafts. So he's still, it looks good, but if you stop to analyze his hair, you can like see that there are a lot of beard grafts here on his crown. So when I realized it, nowadays I prefer to blend, to mix this with. Of course, I save a small lane of scalp hair only for the hairline, and then I start mixing the beard grafts or body hair with the scalp grafts, so that the result can look very natural. But you know, in this case, if I only have beard grafts to transplant, even so, it would still look good and natural. Why? Because he has a lot of transplanted grafts from the scalp already placed on his crown. So it will be mixed. It won't stand out the beard. One case that I've sent you, if you can try to show it, it is a class 6, a sleek bald class 6. If we can see his crown,
go to the next one.
beard grafts are standing out a little bit.
Next
Yes,
one. I might have not had them all. Is it this guy? No.
not this guy.
Is it on your Instagram?
Yes, but it will be hard to
All the way at the
find
bottom.
it.
Yeah, I
Yes,
might have not, because there was so many pictures. I don't think I had
oh,
the time to add them all. But I hear what you're saying, and one thing that I've always thought about for myself, is I have pretty straight hair. This guy, the patient that we were looking at earlier, he has kind of like curly, thick hair, where it wouldn't look that weird, right? But for like someone with me who has pretty straight hair, and then to have like just beard hair in one section might look a little off. So I've always wondered, like, if I wanted to get my last procedure, I keep saying last, but if I wanted to get one more procedure, and I don't have that much donor left, what would be the best case scenario for someone like me? And I know a lot of people are in that situation where they've had, multiple procedures, and they still want more density in the crown, or they want more in the side humps, and all they have is beard. Is it possible to use just beard
yeah.
grafts without it looking
Yes,
weird?
yes, absolutely. It's possible. It is possible, and we should also take into account that we need to try to match the contrast between the areas with low density, the side humps, or the lower part of the crown. And it may be a good idea to intentionally over harvest the donor area, so that those contrasts match, so that you'll be uniform with no difference between those two areas. It might be a good idea to do this homogeneous depletion, but even if you don't want to do this, the beard grafts would be also a good idea. And if you are not, trusting on this strategy so much, we can also harvest from the chest if you have chest grafts, so that it can look smoother, a little more smoother with chest grafts, not that curly, thick beard,
Yeah. Let's just before I let you go, Dr. Pittella, we got some questions here. I want to make sure that we answer some of these questions. What do we got?
We're gonna go back a little bit. It's, one of the questions is how many or what's the percentage of your patients that don't want to take medication?
What's the percentage of the patients that don't want to take medication
Okay.
in your practice?
So During my consultation takes a lot, almost 1 hour of consultation, and 6% of the consultation of this time is talking about the importance of the clinical treatment, to try to avoid further miniaturization of the native hair. So I talk a lot with the patients about this situation, so they understand the need of taking the medications, and I'm clear to my patients the side effects of oral minoxidil. uh, they are really important so that the patient can notice if anything happens, any palpitation, or a low blood pressure. They can tell me, and so that we can adjust the dosage. And also I tell them that I don't use finasteride, and the patients like feel relieved that I don't use it, because uh, if you're willing to do the clinical treatment, you should be prepared to do it for your lifetime.
Lifetime.
Yes,
Yeah.
it's not like I will start today for 6 months and take it and then abandon it. No, it's not like this. So if a patient is willing to take finasteride, he may need to take it for his entire life.
Some in some occasion, you need, like, he may have some side effects,
Yeah.
So the percentage, it's a really a small percentage of my patients that does not want to use anything. If they don't want to take oral minoxidil, at least the topical minoxidil.
What's the percentage of patients that get side effects?
Yeah, in my practice, I see very few side effects with oral minoxidil, and sometimes the patient refers like a mild headache when they wake up, or uh, tiredness, like
Fatigue.
with no explanation. Yes, fatigue with no explanation. So this may gives you the hint that the patient has a low blood pressure, and then we need to adjust the dosage. And I cut the dosage in half, and the patient may still try to use it. It's rare, really. It's not very common.
Got it. Let's go to the next question.
This is going back to you guys' topic about a larger head. They asked, they advise a patient with a big head tend to have more donor hair too, so it balances out, I presume.
Is that true? So if someone has a big, and this has been sort of like the argument that people have brought up, someone with the small head has less donor hair than someone with a big head, but then someone with the big head has more area to cover, so it sort of like balances out. Is that true?
Compensates.
Yeah.
No, that's not true. No, absolutely not. Because yeah, the school size maybe is not the main point of it. The bald area is what matters. But the patient may have a long skull with large donor area and a short bald area, or he may have a wide skull with large bald area and a narrow donor area. So this is not true. Even a patient with a small skull, he may be a small skull, but with large, it does not work. Like, it's not very proportional. The skull size is not proportional with the
Donor.
donor area. I understand
The concept.
yes, the logic, the concept, but it's not. It does not work like this. But it's very interesting point of view.
Yeah, I always thought that, it doesn't matter that uh, your skull is small. It doesn't mean that you're going to have less grafts, because someone also may have just more donor density, more threes and fours and stuff like that. So it doesn't really matter. But it sounds like the skull shape is really what matters. Like someone with a really like large, wide skull with that's a class 7. They're gonna have a
Yes,
humongous
yes, maybe
amount
the
of area
shape.
to cover.
Yes,
Yeah. Let's go to the
absolutely.
next one.
Next question: does fibrosis after one FUE make subsequent FUEs more difficult?
Does fibrosis after one FUE make subsequent surgeries more difficult?
Yes, 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 it makes. But depends. It depends on the surgeon that have operated the patient. Why I'm telling so?
Mm,
Because when I operate patients that underwent surgery on head transplant meal, like in Turkey, uh, they have a very damaged donor area, and the harvesting it's much more difficult on those cases. And in my opinion, this is because they use a wide punch with a large punch diameter. So the fibrosis on the subcutaneous tissue, it's much higher, is greater than the one compared the patients that have been harvested with a narrow punch. Like when I
mm,
do procedures 1 year apart from the other, yes, I find fibrosis, but nothing compared to that those patients that I've mentioned that went to head transplant meals. So yes, this is true, but it will depend on the punch size that was used in the previous surgery.
mm. Perfect. Uh, let's go to the next question.
There is a very interesting question
Get
here.
more
It says,
lifetime graft by
I'm
starting
sorry.
Oh, sorry. What you did you want to go to the interesting question? Let's go to the interesting question first, and then we'll go back to that one. What's the interesting question, Dr. Pittella?
Okay, it's if you intentionally harvest the donor area, can you refill it with body hair? Is it a feasible strategy?
Donor restocking.
This is a very good question.
Mm-hmm.
Very, very good question. Because I've just talked about intentionally over harvesting the donor area to, whatever the purpose. And yes, it's preferable to have body hair on the donor area than in the scalp. Yes, that's correct. The problem on that is you will need another procedure. You need another surgery to do this. It's not like I will over harvest the donor area, the scalp donor area, and transplant to the bowel areas, and in the sequence I will harvest chest hair or beard to place on that small holes that I've left on the donor area. So I will need 24 hours to do this. It's not feasible in the same procedure,
Yeah.
but in another procedure, yes, it's feasible. It's a very good, very interesting approach, a very good approach indeed. What do you think about this, Melvin?
Yeah, a few doctors do that. Dr. Bazanga does that. Dr. Mwamba does that, but it hasn't gained as much popularity. There's one guy on the forum who goes by Mustang. He's had, I don't know, like 13,000, 14,000 grafts, all in small procedures. He's had maybe like, I think, 12 hair transplants. And so he's intentionally, depleted it and over multiple surgeries, and it did work. But the only issue was that he did have to live with a depleted looking donor for a little while. So if you're okay with that, if you're okay with the donor not looking that good, then it's an option. But I think for me, I would rather try to maintain the integrity of my donor as much as possible. Um, dang it, he left. We lost him again. Um, well, guys, I think we're gonna call it a day. We've been here for an hour. Let me try to answer some questions that came in and see if I can answer them. And if he joins back in, then we'll add him back. But we have another doctor that's signed on to Verteporfin. So for those of you who joined late, he said yes. There we go. Okay, so we missed you again. Yeah, so I think that the integrity of the donor is important, but it's definitely a novel idea to over harvest intentionally to try to get it all homogeneous. Um, and like I was telling the people just as you signed off here, uh,
Mhm.
we got you to agree to do a verteporfin trial. I think that's very important. So the people that are joining in, he said yes, he will do it. There is a website called verteporfin.org, which I'm going to send you, that has all of the information that you want to get. It also has an ability for the public to crowdsource to help with the cost of the verteporfin and things like that, to help funding, because it does become obviously expensive because the vials are expensive, and hiring outside pathologists and all that stuff can be very costly. So once you get started on that, we'll get you added on that as well. Let's do one last question before we let you go. What's the
Yes.
last question here?
Let's see. If fibroses make subsequent FQE more difficult, does that make mega sessions a better idea? So you do it all in
Mm,
one go.
yeah. So if fibrosis makes it more difficult to get hair transplants, is it better to just do a large mega session, um, to to reduce
Yeah,
the risk?
this seems to be a surgeon's question. Like it
Hmm.
seems this is yes, absolutely. Yes, you're correct. Yes. That's why I at once try to, extract as many as possible in one day. As long as the patient needs it, of course. So this is a brilliant question. Yes, you're correct. I assume you are a surgeon, a hair restoration surgeon, to ask such a good question, a precise, an accurate question.
Now, to play devil's advocate, someone on the
Go
flip
ahead.
side might say, well, you do a huge mega session. Now, if something goes wrong for whatever reason, the grafts don't grow. Now he's not going to have much options, right? Because now he used it's like gambling with all of your money, right? Put it all on you're taking a big risk as a patient, um doing such a
Yes,
large amount,
yes,
because you're
yes.
taking almost all of your donor in one shot. Someone would say that that's not a good idea. What would you say to someone like that, just playing devil's advocate?
Good question. This is a good question. The answer for this is very simple. If you know the surgeon that is operating you, you will know if he's able to do it or not. You know, if you do not trust the surgeon, or if the surgeon does not trust himself to do it, it's not a good idea to do. Yes, because it's dangerous to do it. Not only because if the surgeon does not distribute the grafts, the extraction, uh, in an even manner on the scalp, you will get patchiness, you will get holes, and it's not going to turn into a good looking donor area. And also, when implanting it, you may have necrosis if you implant with a very high density in a very large area. So the surgeon
Mm,
should be prepared to do it. It's not easy to do it. It's not just harvest and the grafts will be
implant.
automatically implanted on the scalp. So what I would say is, yes, problem happens, may happen. That's why you need to know exactly who is operating you. So the head transplant mill, they try to do this, but I don't know what happens. They just simply can't do and destroy the donor area and destroy the transplanted area as well. In those cases, the patient is his the dream of hair restoration is lost because there's no donor area, there's no possible good outcome for those patients. This is very sad, but I see
Yeah.
it on very often here on my clinic.
Yeah, so just to summarize it, if you're gonna get a large mega session where you're gonna do almost all your donor, you better be sure of the doctor who's doing the surgery, because that you're putting all of your trust into that surgeon. And
Yes.
I can count on one hand the number of doctors that I would trust to do that large of a number. You know, you're one, Dr. Sethi is one, you know, and a couple of other doctors that I would trust. Aside from that, no, definitely not. You know, it's probably wiser to just do a small session and see how it grows.
Yes.
Well, thank you so much, Dr. Pittella. I'm gonna get you all the information for Verteporfin, and hopefully, in the next few months, we'll get a trial out of Brazil, and we'll really get a
Great.
global outcome on this. So, thank you guys. Till next time.